The definition of advanced prostate cancer is a fairly broad one, and people think of this in different ways, and it really includes a diverse or heterogeneous group of men, so men that may look almost nothing alike. In my mind, and I think in the mind of most prostate cancer experts, advanced prostate cancer is any prostate cancer that we know we can no longer cure, and I think that's a really important distinction. There has been one immunotherapy FDA approved for the treatment of castration-resistant metastatic prostate cancer, and that is Sipuleucel-T or Provenge. This medication is sometimes somewhat complicated to give. It involves apheresis, or the withdrawal of white blood cells from an individual with prostate cancer. Those are sent off and processed and then reinfused back into that individual after they're educated. So what we mean by this is that we are exposing a man's white blood cells, or the immune cells that we've withdrawn from him, to prostate cancer antigen, or prostate acid phosphatase, a protein that is found on the surface of most prostate cancer cells. So the white blood cells or immune cells from this individual man see what a prostate acid phosphatase or PAP molecule looks like, and they get very revved up about it. They are reinfused back into the individual, and because they're so revved up against this protein on the surface of prostate cancer, they attack it. And the goal is that we want it to attack it to the extent that they kill as many cells as possible. So Sipuleucel-T is the first and only immunotherapy that is currently approved. It's important to recognize that this is approved only for men with metastatic castration-resistant prostate cancer, so a fairly advanced prostate cancer. But men who receive treatment with immunotherapy must be asymptomatic, meaning they can't have a lot of symptoms, pain problems, or other issues related to their prostate cancer, because they must have a life expectancy of at least 6 months. And a lot of times when men have very out of control symptoms, it may be because their prostate cancer is so advanced that they may not have 6 months to live. And so they also have to have what we call a long PSA doubling time. So the prostate cancer has to be growing at a relatively slow rate, is the bottom line. The reason for this, and the reason that we want to make sure that we give this medication only to people who have a fairly longer life expectancy, is because these immunotherapies do not work immediately. They're not what we call cytotoxic medications. They don't go into cells and cause them to explode and die immediately. They actually take a longer route, a slow process of educating the immune system to start a long-term battle with the prostate cancer. And their peak effects, we think, don't come for some time. So we do want men to be sure to have a life expectancy that will allow that immunotherapy the chance to work. Androgen deprivation therapy is also called hormonal therapy, or ADT, and this is a therapy that actually acts on the pituitary gland in the brain to cause the testes to produce less testosterone. Testosterone is the food or the fuel that prostate cancer cells need to grow, divide, spread, and cause problems. And so when we stop the testes from making testosterone, we lower testosterone in the system and we starve the prostate cancer cells. So these shots act to lower testosterone in the system and starve the prostate cancer cells. There are lots of different versions and formulations of these ADT injections, from 1-month injections to 6-month or 3-month or 4-month injections. There are lots of variations on the theme, but they are all injections, and they all act through feedback loops, hormonal feedback loops through the pituitary gland to lower the amount of testosterone in the system. We have some novel hormonal approaches to treatment of metastatic castration-resistant prostate cancer or more advanced prostate cancer. And these approaches work through the testosterone pathways but are added on to ADT, or the hormonal shots that men are getting at baseline. When men have really advanced prostate cancer or this castration-resistant prostate cancer, they continue the ADT hormonal shots, and that they go on forever because we never want to re-expose prostate cancer cells to high levels of testosterone. We always keep them at a minimum. These newer drugs further lower or inhibit the testosterone pathway, or that androgen pathway. One of these drugs is abiraterone acetate, or also called Zytiga. And this drug works through inhibiting the production of testosterone through a steroid synthesis pathway inhibition that stops the adrenal glands from making testosterone and stops the tumor itself from making testosterone. Interestingly, prostate cancer cells, as they evolve and try to cause problems, start making their own testosterone, which is obviously not good. And so the abiraterone or Zytiga stops that process, further starving the prostate cancer cells. The important thing to recognize is that when we stop the production of testosterone, we're inhibiting steroid synthesis, and your body needs other steroids to maintain its normal levels of blood pressure and salts in the blood. So we always give Zytiga with prednisone, 5 milligrams in the morning and 5 milligrams at night, to restore the normal steroid levels or cortisol levels in the system and prevent complications that can come with really low levels of that. And so the prednisone is a critical part of treatment with Zytiga and really prevents someone from having blood pressure that is dangerously high or potassium that is dangerously low and other complications. The other approach to blocking the androgen pathway or the testosterone pathway for prostate cancer is an approach with a medication called enzalutamide or Xtandi. This medication blocks the androgen receptor, or the receptor that the prostate cancer cells use to get activated with testosterone. I think of it as the prostate cancer cell's mouth. It normally eats the food of testosterone, and we're putting a muzzle on that mouth, and we're not letting the testosterone get into the cell and activate it. Enzalutamide is fascinating in that it not only blocks that mouth, but if somehow the mouth is activated, it stops it from moving into the nucleus or the center of the cell, and it stops it from undergoing the process that it does in that nucleus to make proteins and cause problems. So it blocks it at multiple levels. Enzalutamide or Xtandi is not given with a steroid, it's just given on its own, and is usually, just like Zytiga, very well tolerated. Recently, a trial was completed and reported on radium-223 or Xofigo, and it's called the Alsimca trial. It was an international, multi-centered, randomized controlled trial, which in doctor speak is the most important, most believable type of clinical trial. It enrolled thousands of men and looked at the survival of men treated with Xofigo or radium-223 versus other treatments, standard of care type treatments, things like steroids or other treatments that may have become available. The men included in the study were either already treated with chemotherapy, docetaxel chemotherapy, because that's the standard of care, or they were too frail or ill to get that treatment. And so it was a diverse population of men at all stages of their prostate cancer. At all stages of advanced prostate cancer, I should say, because all men had metastatic cancer in their bones or prostate cancer that spread to their bones. The men who received treatment with radium-223 or Xofigo lived a little over 4 months longer than the other men. And this actually 4-month mark is what we see with a lot of our advanced prostate cancer treatments. But the important thing about Xofigo is that it's a new approach. It's a radiopharmaceutical, these little smart bombs that go directly into the bone and decay there and don't cause a lot of side effects elsewhere. It's very well tolerated, so even very sick people can get this treatment and do very well with it. And so it's been a great advance and a wonderful addition to our options for therapy for this population. The one caveat in this is that all of the men who were in that trial had bone-only metastatic disease. So the areas where the prostate cancer had spread was just in their bones. It may have been in every bone in their body, but it wasn't anywhere else. It wasn't in their liver, it wasn't in their lymph nodes, or anywhere else. And so this is important because when we use this medication, we recognize that the only places that will be attacked by this medication are the places in the bone. And so if you have cancer that's in the lung or in the liver or the lymph nodes or elsewhere, it will actually not be affected at all by this treatment. So currently it's approved for men with metastatic disease in their bones, and it does stipulate that it should be men with only metastatic symptomatic disease in their bones. Sometimes we do stretch that and treat men who have disease in their bones and a little bit of disease, maybe in lymph nodes or a low volume of disease elsewhere. But I should say that it's not, the label's not written that way. And if you are going to use Xofigo or radium-223 in that population, In my practice, I always pair it with something else that may be effective in lymph nodes or in those other areas. I would not feel comfortable treating someone who had disease that was outside of the bones with that medication alone, because I would know that I wouldn't be addressing the other disease at all, and it could be growing and causing a problem even while I'm treating the disease in the bones. Castration-resistant metastatic prostate cancer is also treated with chemotherapy. Importantly, docetaxel chemotherapy was the first drug approved for castration-resistant metastatic prostate cancer that ever prolonged life. So this was approved in 2004 and has been with us since that time, and all of the newer medications are really coming on the heels of docetaxel chemotherapy. Docetaxel chemotherapy was approved because it prolongs life by about 2 to 3 months in this population. That doesn't mean that men treated with chemotherapy will live for 2 to 3 months, but it means that the amount of time that they would normally have had is longer by 2 to 3 months. And it's a taxane chemotherapy given through a vein once every 3 weeks. The infusion takes about an hour to an hour and a half, and between all of the setup and preparation to get the infusion and the process, it's probably about a 2-hour visit. Docetaxel chemotherapy, like any chemotherapy, can cause some hair loss, some fatigue, mild nausea, but generally men do very, very well with this chemotherapy. It's important to recognize that docetaxel chemotherapy is one chemotherapy drug, and in the scheme of things, one of the more gentle chemotherapy drugs. It's not a combination of 3 or 4 drugs like we give for some treatments. It doesn't cause people to have to move into the hospital for 3 weeks and receive nursing care indefinitely. It is a relatively mild chemotherapy that's potent against prostate cancer, but relatively mild in terms of its side effects on people, that we give in an infusion center as an outpatient once every 3 weeks.